This report brought to you by the Richmond Club, where investors and high-growth companies meet.
Our next presenter is the Executive Chairman and CEO of GeneNews Ltd. Please welcome James Howard-Tripp.
Been introduced. So GeneNews is a public company. We're listed on the Toronto Senior Exchange. Ticker symbol is GEN, so pretty much everything that you need to find out about us from a stat perspective is there. So what is key about us? If you look at where we're going, we believe that this year, by end of the year, we will be doing in excess of 30 million in revenue. So it'll be our first big year from a revenue perspective. We believe that that will make us fully profitable. We're running at low levels at better than a 50% gross margin. Running at the high levels like this, we're probably in excess of about 70% gross margin. The big opportunity that we're focused on is one called Aristotle, and Aristotle is in fact finding 10 cancers off of a single sample of blood. That, as I will show you, is about a $2 billion opportunity, and we expect to be there from a launch perspective within about 2 years. We have a solid commercial plan in place. I'll explain that as I walk through the various pieces. And we have an experienced management team and board. We've actually all done this before, and we've all done it successfully. If you look at the strategy behind this, it's all about finding cancer at its earliest stages. If you have cancer and you find cancer late, that's an obvious. When cancer grows to be sufficiently large enough, it becomes problematic, it becomes symptomatic, we find it. The big thing is to find it early, and so that's the holy grail in terms of where everything is. By finding it, we can focus behind the Aristotle platform. I'll explain a lot about our science in a moment and why we believe it's critical. We are 3 separate pieces to an organization. We're putting all of this together and essentially refocusing the company. Together with that, we will undergo a name change, and so we essentially come down to everything under a single banner. When you go to what Aristotle is, or where you go to what this sort of early stage of cancer is, we're more advanced than the competitors in the marketplace. And the competitors are groups like Grail. Grail has got a multi-billion-dollar valuation at this point. It essentially is as yet nowhere in the science. They're still learning. I think we'll show to you that actually we're ahead of them, and in actual fact we already have proven science. And then we have very clearly a commercial strategy in place with the billion-dollar potential. So why do you want to find cancer early? And in many ways it's very obvious. But if you look across the 4 areas that we're currently focused in, which is colorectal, lung, prostate, and breast, you'll see that if you find colorectal cancer early, your 5-year survival rate is about 90%. If you find it late, it's about 11%, and something like 2/3 of colorectal cancers are found late. If you go to lung, it's actually even worse. The late stage survival rate with lung cancer is about 6%. You find it early, we do better than 50%, and we find the right kind of cancer early, you're kind of in your 70 to 90%. So it's absolutely clear, and we can work all the way through this as to why you want to find it early. In addition to that, the costs are just massive. We find it early, the cost of treating that particular disease is a fraction of what it is when you have to treat it late. And I'll talk about this even more. If you move now to very large employers, particularly those that have hundreds of thousands of employees, you can see where the benefit is. The only reason for talk to this is it enhances population-based screening. And so that's something you'll hear a lot more about. If you cannot find it early, you cannot do the broad-scale screening, you cannot look at population-based. So it sets us apart from everyone else. And because we're blood tests, absolutely key, we're a blood test that has a very high adoption rate. And I'll talk a little more about this in a moment. So if you look at the science, this is what it's all about. We've been at this for about 20 years. In the beginning, everyone said, you can't do this, you cannot be done. It took us about 5 years of wandering in the wilderness before people began to say, yep, actually, you probably can do this. By the end of 10 years, it was becoming accepted. Now it's by and large known as liquid biopsy, and we're one of the founders of the entire liquid biopsy principle. And I'll walk you through this a little bit, because it's based on a scientific observation that circulating blood reflects in a detectable way what is occurring throughout the body. And so if you think about that, it's exactly what? It's dynamic, it's constant, it's ongoing all the time. We're based on whole blood. It's an RNA transcript-based profile that we develop off of your genes, and as a result of that, we can develop a personalized gene expression signature that tells us whether you likely have the disease or don't have the disease, and whether it's early stage, mid stage, or late stage. We can also track it over time. And again, all of this off of a sample of blood. Key thing, all of this off of a sample of blood. And the way it works is that as blood circulates, and if you think about cancer specifically, communication occurs between the cells in the blood and the tissue, so on an ongoing basis. Tumors are known to affect gene expression profiles, and I'm quite deliberately reading a little bit from the slide so that you can focus on that too. But it known to affect gene expression profiles of these circulating cells, so leukocytes, lymphocytes, T cells, B cells, natural killer cell, etc., etc. So if we take a sample of blood and we look at this, we can actually tell whether someone might have colorectal cancer, where the expression pattern would look like that, versus someone doesn't have colorectal cancer, which looks like that. As we begin to look at the overlap, we can give your increasing probability in terms of having it. And so we can actually see development of the disease as it comes on as well. And that part is huge because it means we can track you afterwards as well. So post-treatment, we can also track it afterwards. So most groups, as I was saying, say, well, we think we can do this. This is what we're setting out to do. We think we can do this. We're going to stand in front of you and tell you we absolutely can do it. How do we know? Because ColonSentry, which is the first of the tests in this, is for colorectal cancer. ColonSentry has been in the market for some time now, and in actual fact, we're publishing within the next day or two data on a full 100,000 cohort of patients in the United States that just proves very solidly why we can do it and how we can do it. In this, what we're doing is each gene, we look at 7 genes, each of 6 genes is paired with the 7th gene, and it's exactly what I was telling you. No, we see nothing there that says any indication that you may have colorectal cancer. Yes, very high indication that you likely have colorectal cancer, or the in-between pieces in terms of where it goes. We will tell you that we're not diagnostic, and it's a very careful play on the words. The diagnostic in this case is in actual fact the piece of tissue that is in front of the pathologist, and it's the pathologist that will always tell you whether you have cancer or not. Medicine is not yet at the point at which we would look at the results of this and say, right, we immediately, you likely have colorectal cancer, we're immediately going to schedule you for surgery or chemo. It will always run that extra step. And so what we want to do, though, and I'll switch over to lung cancer here. In lung cancer, first of all, only about 3% of patients get screened. And this is the high-risk people. These are people that have got 20-pack-year histories of smoking. Only about 3% get screened. Why? Part of it, they don't really want to be screened. 2, the other part is that you have to go through low-dose CT. That's about half a day of your time you've got to take. You've got to go and get screened for that. It's an awkward procedure. A lot of people don't like it. There are radiation concerns, etc., etc. So people don't do it. When you ask them to undergo a blood test, if it's done particularly in office, exactly right, 95+% of the time, here's my arm, go ahead and do it. If low-dose CT says you likely have lung cancer, 96% of the time it's wrong. 96% of the time it's wrong. So you've now got to work down an entire process of trying to sort it out. If you use our tests, about 80% of the time we'll tell you whether that test is correct or not in terms of where it is. Additionally, we find it 2 to 4 years earlier than low-dose CT will. And initially we thought there were issues with the test, that the test was not sensitive enough. We in actual fact found no, it was perfectly sensitive enough. It was low-dose CT that was not. It takes low-dose CT only picks up tumors when they're about the size of a pea. We were finding it when it was tiny. And so if we tell you you quite probably have lung cancer, you now fall into an active surveillance program where we will track you for minimally 2 years until it actually grows till it's large enough and we can see where it is. Now you've got your rule-in aspect, you know that almost certainly what you're dealing with is lung cancer, and you move on from there. And so those are the benefits. I'll give you one final piece because it'll shorten some at the end. When we do that, if we're working with the plans, if we're working with the large healthcare plans, it's a 40% saving. 40% saving on healthcare costs if we use our tests in combination first. So it is huge. Plans will normally make a change if it's a 2% saving. We're significantly better than that. So this is a little bit about Aristotle. Aristotle is where we're going. Aristotle is the big program, and literally it'll be the first time off of a single sample of blood we can do 10 cancers. So we can actually screen for 10 cancers. We can find them early, we can stage them, and these are the cancers that we would look at. There are 2 things to take away from this slide. One, the 10 cancers: bladder, colorectal, liver, nasopharyngeal, stomach, prostate, and then a suite of female, which is breast, cervical, endometrial, and ovarian. A lot of these are very difficult to screen for at the moment. So we will not only be providing a new way of looking at it, but we'll be actually doing it in that group. The second thing is take a look at the sensitivity and the specificity. And we compiled this in a way that is directly analogous to what else is being developed in the marketplace. And you'll see that essentially we're above 90% on all of those. And in a number of them, we're very high 90s in terms of sensitivity and specificity. It'll probably soften a little as we do the full clinicals, but it's a huge opportunity. We're not only in cancer, we're in neuroscience. As I said, we've been developing this for 20 years. So we're in neuroscience, we're in gastroenterology, cardiovascular, musculoskeletal. Neuroscience is an area we absolutely would want to go to. We were guided initially not to go there because we were finding a problem for which medicine didn't yet really have the solutions. That started to catch up. Timing actually is very appropriate to begin to move towards neuroscience. We have a partnership with Dietrich Stephan, LifeX. LifeX is out of the University of Pittsburgh. And so Dietrich Stephan is one of the noted experts in this entire area. And LifeX itself is, as it's moving and changing a little bit, we're very tight with that. But Dietrich was the University of Pittsburgh Medical Center. He was head of human genetics. If you want to talk to health systems, one imagines you might want to talk to one where he was at. So it's very useful for us. 2, LifeX takes young companies like ours in terms of where they're in the growth phase and puts as much effort as they can behind them in terms of helping you to grow up. And so part of all of this is there. And so what does Dietrich say? As one of the pioneers of the liquid biopsy, he believes we've developed the Holy Grail, which is a suite of tests that have the correct sensitivity and specificity to detect cancer early and perform correctly as a screening tool at the population level. That's an absolutely critical statement. So, commercialization model. This is purely Aristotle revenue as we've modeled it out. It's about a $35 billion opportunity that we're competing within. We believe we can also be first. We believe we can be there before anyone else. We're on target right now to actually look at market introduction within about 2 years. And we will introduce it through the commercial pathway that we're already putting in place. This is separate to revenue that we're developing off of the 4 tests we currently have in the market. We have we're US focused, we're entirely US focused. We may very well do deals in a series of other countries, but at the moment we're entirely US focused. We have a single reference lab which is in Richmond, Virginia. It's CLIA and CAP approved. Our products are New York State approved, which is second only to FDA in terms of where you get your approval. And by the way, our tests are what are called LDTs, laboratory developed tests, and 98% of the tests in the US are LDTs. You do not need FDA approval to take your tests into the US. So it's a huge approach, but we've taken through New York State, which is a superb recommendation for us. Also, if you CLIA and CAP approved, you can't provide tests or bill the US government without being CLIA approved. So we're CLIA approved as well. I'll focus just quickly on the non-compliant patients at the bottom, because that's our entry point as we're going in. And we talked about the fact that people will do blood tests where they may not undergo low-dose CT screening or a colonoscopy or do stool tests. And you'll see that fully 33% of patients are non-compliant with colorectal cancer screening in the US. It's, as we said, 97+% are non-compliant with lung. When you go to men with elevated PSA, and looking at the age group around the table here, we're probably all concerned about what PSA readings are and where they are. If you get a raised PSA, 70–80% of the time it is not cancer. It's probably benign prostatic hypertrophy or something else. However, if you get a raised PSA, it's typical to send you for a biopsy. Biopsies, in actual fact, cause a fairly high degree of side effects. So we're one of the ways of being able to sort that out immediately. And it's a similar process when you go with women with breast cancer. About 50% of women have dense breast tissue. Mammograms actually are not very good at discerning breast cancer in women with dense breast tissue. So we're helping with all of these. When I go to what we're focusing on, we're really focused on 4 very large areas. First of all, it's the physician practices. Everything always starts with small physician practices, but it's very labor intensive. You by and large tend to need reps in the field to grow this very, very significantly, and you need to work through the billing companies, which is a protracted process and takes time. So together with that, we've moved much more to where we can get fairly quick billing or where we can get cash payment. So we're going to the large healthcare systems, we're going to high-risk patient populations, and we're moving down the direct-to-consumer approach. If you go to the health system opportunity, and this is one of the groups that we're working with, you can see that it has multiple hospitals, it has a large cancer center within it, it has over 1,000 physicians, it has about 2.8 million patients, and you run through that. If you run it all the way to the bottom, and you drop right down to the bottom number, that's worth about 36 million to us in a year. So we're moving down this path very, very rapidly. When you look at why they may want to do it, there are 3 reasons. One is we're going to do a better medical job for them than they currently can do. We're going to be able to introduce population-based screening. We can find cancer, but we can find cancer early, which means they get to meet all of their measurements, and it's called HEDIS measurements, in a much better way. So we can do a much better medical job for them. Second on this is that we actually generate revenue for them within the hospital. And if that sounds a bit odd, if 40% of your patients will not have colorectal cancer screening, we can drive those patients in the door. If 97% will not have lung cancer screening, we can drive those patients in through the door. And so you get that entire spillover as it drives through on everything, through pathology services, through oncology services, etc., etc. So we're very positive revenue generation. In addition to that, you come to this, which is cost cost saving. And if you look at this is ColonSentry, we can save 24% on colorectal cancer screening. So groups pick ours up, it's just huge. Now I'm going to move you over, I'll jump you over quite quickly to the high-risk employees. And firefighters, an example of that, we're actually very active in terms of screening firefighters. Firefighters have about a 60% chance of dying of cancer. It's a high-risk occupation. You're breathing in noxious fumes, you're around gasoline fumes, you're everything that runs with that. And so as we're screening them and our data's coming forward, if the usual population group would have a risk like this, firefighters has got a risk like that. So again, what we're trying to do is to find it early. But you can move this to very large employers as well. And so the union would be one group here, but you can also go to very large companies. So you drive down that, if we can show a 24% saving off of a single product, ColonSentry, if we can add lung, which as I mentioned is about 40%, you can drive it through. It is huge. And so a comment from one of the groups that we're talking to just last week said they have looked at everything out there. Everything out there, and they cannot figure how to contain their costs in terms of what's called catastrophic events. Catastrophic events is your employees getting cancer. We can change that. Have we got their attention? Absolutely. I will go just very briefly to the concierge medicine opportunity. This is growing. This coupled together with direct to consumers in the US is now becoming huge. The average family of four in the US last year spent $18,000 on healthcare. And by that, I mean that's just their insurance. It went up 16% last year. It went up 18% over the year before that. People, therefore, are making smarter choices. They're moving towards high deductible plans, which means they have much more control over where they actually spend their healthcare dollars, and that's an area that we're beginning to work in. These are the people that want to be screened. In addition to that, as we were mentioning, with all of these, other than with the small private practices, we get paid either on 30-day invoice or we get paid cash up front. So it's a way around the entire billing model, and it'll work much, much better. So I'll go to just building the US footprint as we go on out. Sorry, I think we may have lost it. Let me just see if I can get hold of these in. If you look at where we're going, we're building out very strongly. The physician practices are growing and are growing constantly. We're actually seeing very significant increase in terms of where we are. We're growing out through the collaborative Salesforce side. We're actually in the process of bringing on reps of our own, but we're also growing out through the collaborative Salesforce side because it's an obvious way to increase reach. The high-risk employee group is starting to grow very nicely, as is the large healthcare side. And we're on record as saying this first quarter, we actually expect to have a significant number of announcements as we move forward, but it actually sets the stage for the rest of the year. And so really, in summary, focus is exactly as I said. It's on finding cancer at its earliest stages. We believe we can do it in a way that actually we haven't seen anyone else there at this point be able to do it. So we need to keep the leadership, we need to keep the momentum, but we believe we can get there before anyone else. We are going to make it easier for everyone in that we're going to refocus essentially around Aristotle, around all of the pieces. We're not just about the 4 tests we have in the market, we're about these 10 additional cancers that we can now take forward. It is a multi-billion-dollar market opportunity. We're priced at a fraction of where the competitors are, which is a good thing for us as an entry point. And we think we've got a very good commercial strategy because obviously as Aristotle comes forward, one would imagine as we complete the clinical work, we may want to work with some of the large healthcare partners we're with so that at the point at which Aristotle fully comes to market, it's already in place and we drive it that way. And with that, I'll end there.
This report brought to you by the Richmond Club, where investors and high-growth companies meet.
If you've enjoyed this video, please let us know. You've been watching the Richmond Club Report. If you've just come across this channel, please feel free to subscribe. I'm sure you'll find a lot of interesting and profitable investment ideas around here. We'll see you again soon on the next video. Cheers, guys. Have an amazing and profitable day.